the most important key. And I would just like to say that now this meeting is also on YouTube live, because always we face the issue of numbers, and howsoever big we try, but it always exceeds the maximum possible limits. So that is now on live stream. The most beautiful thing about Sanbepa is very active participation of all countries from South Asia, from Bangladesh, from Nepal, Sri Lanka, Bhutan, and India. So, it's a beautiful bouquet which is there, and we are privileged to have representation from all the respected seniors as advisors for Sanbepa and very active members managing the team. So, again, as I say, it's a very proud and a privileged moment for all of us. We are doing this activity every month, and we are getting very positive reviews about the topics, about the content, and
Zafar,
yeah.
I wanted to check. So, on the Sanbepa website, do you have the capacity to host, the individual sessions and things, or any other educational material, or is
Yeah.
it still too early?
No, actually, till now they are not fully uploaded. Different countries are providing us the platforms. Like today, it is the
Okay.
new developmental pediatrics chapter. Otherwise, the Google Meet is being provided by Nepal. Sometimes the Google this thing Zoom is being provided by uh, Sri Lanka. I welcome Professor Ehsan. Sir, welcome. He's the president of Sanvepa, and it's a proud honor to have you, sir. Welcome, sir.
Thank you very much, Dr. Zafar. Thank you all respected colleagues and honorable guests for today. So pleased to see you all again on the same platform for the same cause for the pediatrics of the neurodevelopmental field of our neglected region, that is Southeast Asia. And I hope that we'll keep on moving forward despite many hurdles. Thank you very much.
I think, as Zafar told, that the good things of, I don't know whether you are listening to me.
No, we are quite listening to you, Riyaz sir. Please go ahead.
Okay, so the very good thing which I feel that in Sanbepa is we have added the environmental issues, and we are trying to go for research on environmental impact on this childhood onset disability or developmental disability, because in this subcontinent, especially in South Asia, we have a little bit different, environmental context, like Nepal, Bhutan, Bangladesh. Bangladesh is a lowland, and also the whole region is sometimes, these children, they face lot of political and also mishaps like war and other things. So this kind of things, how do they affect our development? That's also very important. We should think about it. And I think if we think together, and if we can include the environment along with epidemiology on the aspect of disability, childhood disability, that will be a very interesting thing, and that will be example for the whole world. That's
I welcome Dr. Sameer Dalwai, today's moderator. Welcome, Dr. Sameer.
Hello, namaste,
Uh,
adab. Good afternoon.
Welcome, Sameer. Welcome.
Afternoon, sir. How are you? Basaraj sir,
Hello.
Mohan sir, Arnab bhai. So nice to meet you.
Hello.
Ji, when are you
Very nice.
Yes, sir.
when are you coming to Bangalore?
Whenever you command.
No, Arnav, I was asking Arnav ji. Last time we met him, Bangalore.
So, not Bangalore, but I'm coming to Trivandrum. End of
Okay.
August. But the last time in Bangalore, that was a wonderful meeting.
Yes,
And
yes. We had an
connect.
excellent interaction, and that was a UNICEF program.
Yes, and the DEIC there is doing some wonderful work. They've
Yeah, yeah,
continued to
yeah.
do
They,
so
they,
under
they,
your
Yeah,
able guidance.
yes. I remember Samir long time back. Samir was there in Bhopal,
Yeah.
and probably we met in Bhopal together. I don't think you remember me. I'm Riaz from
Yes,
Bangladesh.
yes. Yes, yes. We met at Bhopal. You're absolutely. How
It
are you
was
doing,
it
sir?
was the 2014 National Conference of the Neurodevelopment Pediatric Chapter. I was fortunate to host it at Bhopal, and
Yes.
I think that was where Professor Riaz also came from Bangladesh.
Nice to meet you again.
Yeah, nice meeting you too.
Dr. Sitaraman, sir, are you just let's take your audio.
Nasar is here. I think his
Yeah,
audio
yeah.
is.
Sitaraman,
Okay.
sir. Audio एक बार.
Yeah, good morning.
Yeah,
Can you
yeah.
hear me now?
Yeah, yeah.
Wonderful. That's nice. So before you came in, we had a small PhD. So good. So moderator is very particular, you see.
No, Samir is very, very, for micro things also, he makes sure that everything goes well. Quality should not be compromised.
Thank you, thank you. Yes.
Good.
I was just going back to the issue that Professor Riaz brought up. I think it's a very important one. The environmental context, other contexts, whether it's war, whether it's finance, whether it's the cultural context, I think they play a huge role, a much greater role in our childhood population, and particularly with the children with disabilities. So it'll be really fascinating and important also to focus some of the work through Sandpaper and alliances where colleagues, like-minded colleagues, are coming together. It'll be interesting to see how that develops.
Absolutely.
And if there is any support required, I'm very happy to be involved and pull in other resources as needed.
Yes,
Thank you, sir.
we are now working on a project which is we're looking at the effect of lead poisoning and lead on autism and ADHD, and whether they have got any sort of association or any sort of I mean causality also.
Yeah,
Uh,
there is some work around lead and ADHD already with correlations proven. The autism bit will be interesting to see.
Yeah, and that's what we are trying to do with Shauli is working with me, and in fact, I'm working with Shauli. Shauli is my student, and I
Mhm.
have given her a lead that she should be the principal author, and I'm going to assist her because we are funding this project with a very small amount of money from our institution. There's a we have a yeah, you're right. We have a small budget, and we are trying to yeah help ourselves. Yeah.
Welcome,
We should
Dr.
have a
Anil from
separate
Nepal.
conversation.
Welcome,
Sorry.
Dr. Leena Deshpande, Senior Member of our Neurodevelopmental Pediatric Chapter.
Good afternoon, everyone.
Good afternoon.
Good
How are you?
afternoon.
Good
Good
afternoon.
afternoon,
Hello,
Leena.
Arnab.
Good to see you.
Very nice to
Hi.
see you, Arnab.
Welcome, Dr. Kamaljeet, the President of Neurodevelopmental Pediatric Chapter of IIP Chapter of India. Welcome, Dr. Luna from Nepal.
Good afternoon, everyone.
Good afternoon.
Good
Good
afternoon.
Hi,
afternoon,
Good
Dr.
Kamaljeet.
afternoon. Good afternoon, Kamaljeet Singh.
Good afternoon, Riyaz. Good afternoon, Dr. Zafar. Good afternoon, everyone. Nice to see you, everybody here on time. Dr. Zafar is a magician, but he's a tough taskmaster, or I'll say ringmaster.
I've been troubling Dr. Kavalji since morning. There were some issues, but I really thank him. More than a president, he's a great friend. More than a chairperson of the development chapter, he's a great friend, a great human being, always ready to help out. And I personally thank you, Dr. Kavalji.
Thank you, Zafar bhai.
I think, Dr. Samir, can we start? Should we wait for two,
No,
3
a
minutes?
couple of minutes more. 2:05, you should start sharp.
Okay.
I think I find the 10-15 minutes before disconnecting and chatting, these connections are equally important as the, whatever educational stuff that we do.
Welcome,
Good
Dr.
afternoon,
Leena
everybody.
Srivastava. Welcome. Dr. Leena Srivastava, the past chairperson of Neurodevelopmental Pediatrics chapter. Welcome.
Good afternoon, everybody. Good afternoon, Dr. Arnav. Good afternoon, Sunil.
Good afternoon.
Good
Welcome,
afternoon,
Mr.
Leena. Good
Vikasam,
to
sir.
see you.
Good to see you too.
Very good to see you, Lena.
Good afternoon.
Good afternoon.
Good afternoon to all.
Good afternoon, sir.
Dr. Sivaprakash.
Good afternoon.
Welcome, Dr. Anjan.
Anjan is here.
Welcome, Dr. Priyanka Raikwar.
Thank you, Dr. Zafar. Good to see you after so many years online. Great. How are you?
Fine, fine.
Seeing a lot of stalwarts on the group. Good they could make out time for this. Nice.
Dr. Priyanka, I am Dr. Riaz Mubarak, Professor, Bangladesh Shishu Hospital and Institute.
So,
And I think I didn't meet you before, but uh, good afternoon and nice meeting you.
this is my first time, sir, joining this group. I am a member of ComHAD, Commonwealth Association for Health and Disability. So Dr. Zafar extended this invite. So I said I should make the most out of it, meeting you all. Good to see you, sir. Thank you so much.
Yes, you're welcome. Great to see you too.
Thank you, sir. I was very curious to hear about the lead poisoning.
I think we are exactly now 5 minutes to wait. I think we can formally start it now.
Yes, I think we should start because so we are looking forward to listen to the.
Dr. Basavaraja, sir?
Yes. Yeah, I made a there.
Yeah, sir, can we start, sir?
Yeah,
With your
from
kind
my side,
permission.
it's absolutely fine if Samir gives permission.
No, sir. We are honored, sir, with your gracious presence. It's my proud privilege to welcome our first and foremost the esteemed chairpersons, Dr. Basaraja, sir. He's the past IIP president of Indian Academy of Pediatrics. He's the professor of pediatrics of Indira Gandhi Institute of Childhood, Bangalore. A person with Dr. Samir Dalwai ensured that this group transforms when he was the HSG of IIP to be the group to the chapter which is present today and has been ornamental in guiding us and supporting us in our cause all through. It's also my pride privilege to welcome Professor Riaz Mubarak. He's the advisor of Sanbepa from Bangladesh. He's professor of pediatrics epidemiology at Dhaka Shishu Medical College. icon in epidemiology and neonatology. And welcome both of you, sirs. And on
Thank
behalf of
you.
Sanbepa, uh, we feel honored to present Dr. Arnab Seal, who is the present president of the International Alliance of Childhood Disability Organization. And he has his roots from India. He's consultant at Leeds, but his very presence give us a very different stature as well as endorsement of the work we are trying to do for this part of the world and the children of South Asia. Thank you very much, sir. It's an honor to host you. Thank you, dear Samir Bhai, as always, being the scientific coordinator of this program. It's my proud privilege. He is the director of New Horizons Child Development Center, the past chairperson of Neurodevelopment Pediatrics Chapter, the treasurer of Indian Academy of Pediatrics. Big list of achievements, great achievements for the cause. It's my proud privilege to welcome you. I also welcome the esteemed panelist, Professor Sitaraman sir, uh, the Vice Chancellor of Indian College of Pediatrics, and Dr. Deepak Devedi and Dr. Hashan from Sri Lanka. I would request Dr. Basavaraja sir, who would be chairing the first session, to give the opening remarks.
Thank you very much, Dr. Japar Minani, and our ever smiling Dr. Samir Dalwai, who has been very, very instrumental in working in the Indian Academy of Pediatrics as a joint secretary and treasurer, who has been backbone of our neurodevelopmental chapter with the stalwarts like our past chairpersons like Leena Deshpande, Leena Srivatsava, Kavaljit Singh, Shiv Prakasham, and of course our Vice Chancellor, Professor Sitaraman sir, and many of the stalwarts who has been put a lot of effort to make a neurodevelopmental chapter more uh, challenging and making it in a more spreading up in academic activities across the India. Not only that, and taking it to the international level with the Sanbepa, which has been a credible organization. I had an opportunity to interact with Dr. Arnab Seal when he visited in India a year back. The work which has been doing at the Leeds and also bringing a concept to the India is something which has been a need of the hour. And the real breakthrough of a neurodevelopmental chapter of India, which has been doing a great work in the neurodevelopmental field before the COVID also, but the real breakthrough which has been occurred during the COVID time, where Dr. Samir, Dr. Leena Srivatsav, Leena Deshpande, all together along with Kavaljit and our Jafar, who has been a very, very energetic man, who has been able to spread the awareness regarding the neurobehavioral disorder in India and also taking it to the Southeast Asia. It is something which requires a big round of applause to our Japan Minan, who has been doing a great work. And coming to the today's thing, I'm sure Dr. Riaz Mubarak, our co-chair from Bangladesh, who has also been very stalwarts in the field, and all the things which has been topics which has been relevant has been chosen for today's discussion. That intellectual what we talk about and a disability which has been starting in the childhood. The moment we say childhood onset disability, we most of the time we think about genetics, but we need to be aware something behind genetics. With the change of a climate, what we are talking about, the environmental issues which is been occurring across the globe, where the environment and ecosystem which is really going to play in a bigger role than the genetics alone. Just to give a one example, how the COVID, which has been changed in a whole spectrum of a disease, what we are seeing it today, in the down the line 50 in a decade later, so world is going to be crumpled with a lot of neuro behavioral disorder. If you don't act now, if you don't create a policy which is going to have a big impact on the GDP. What we are talking about in a country's GDP, it is going to be affected by all these things. That's where our international organization like a COMET, Dr. Preeti Raikar Madam is also here, and Sanbepa and our neurodevelopmental chapter. Of course, Indian Academy of Pediatrics with more than 50,000 members. We are always there to take any step which is required to bring in a policy at the international level that will also help the India. And today's deliberation by Dr. Arnab Seal and of course Professor Sitaraman sir, who has been my teacher and guide, under whom I have been trained in SMS Medical College, Jaipur, and of course Ashan and Deepak Divedi, who is going to talk about the pediatrician and brain health, how the pediatrician can play in a role. I'm sure all the three topics are very, very relevant. So it is definitely it is going to be in a very useful interaction that will make a big difference. With these few words, thank you very much, Dr. Jaffer, for inviting me to share my few thoughts, which is related to
Thank you,
the
sir.
today's topic in whatever the way I am there to contribute as an organizational things. Thank you.
Thank you,
Thank you.
sir. I request the President of Sanbepa, Professor Hassan, to welcome all the members of South Asia, the esteemed office bearers of Sanbepa, members from Maldives, Sri Lanka, Bangladesh, Pakistan, India, Nepal, Bhutan. Professor Hassan, sir, please, if you can welcome.
I
It's an
welcome
honor
you
to have
all,
you.
dear colleagues and my respected teachers. You've been always a hope for the better future of children of Southeast Asia for all of us, and we need your continuous guidance regarding this little effort to improve the children with neuro disability in this region. So welcome you all on this Sambipa platform. Thank you very much. Please proceed.
Thank you, sir. With this, we start with the formal presentation. I respect my most respected Dr. Arnab Sheel to please start his presentation.
Thank you, Zafar. Esteemed chairpersons, moderators, and colleagues from Sanbepa. I can see many old friends and also a lot of new ones. And I'm really honored to have this opportunity to be with you today. And thank you for inviting me. I'm going to talk about some core concepts in childhood onset development and disability. Now, before I start, a little bit about myself. I am Arnab Seal. I'm a neurodevelopmental pediatrician based in Leeds. And as aforementioned, I grew up and my training, undergraduate and postgraduate, is in India. But I have been based in Leeds for well over 30 years. And I'm the current president of the International Alliance of Academies of Childhood Disability. It's an organization which essentially brings together all the different communities of neurodevelopment and neurology, the networks across countries and regions, and we all try and work together to develop capacity both in low middle income countries, but also we learn from each other. And if you want to find out a little bit more about the organization, we are at iaacd.net. So the idea of today's talk really is to talk about some foundational concepts in our field. And some of us who've been thinking about these ideas, we think that these core concepts are important for anybody within the field who's working within the field. Doesn't matter whether they are within the health sector or other sectors, or even whether they are a parent or a young person or an adult with a disability, for them to understand some of these concepts. Because with that understanding, it becomes much easier, managing a whole range of different either challenges or making lives better for children with disabilities and their families. So there are 12 ideas that I'm going to share. I'm going to talk a little fast because of the amount of time available. If I am not clear, if anybody wants to contact me later regarding the ideas, I'm very happy for that to happen, and I'm happy for my email to be shared. So let's start. So the first idea or the foundational concept, and this is no surprise, is the International Classification of Functioning Disability and Health. The ICF is something which has transformed our thinking in our field. Some of you will be aware of the ICD. The ICD actually started in the late 19th century as an international classification of death. And then during the Second World War, when there was a lot of progress in medicine with antibiotics and different surgical techniques, the classification changed to International Classification of Disease, which still continues today. But within the next few decades, we recognize that health is far more than identifying disease. It is about well-being. It is about, how can we thrive? So a new framework which came in the early 90s was the International Classification of Functioning, Disability and Health. And you can see, and this is a framework which is probably familiar to most of us, and I'll talk a little bit more about that. Now, one of the challenges of the ICF is that it is not easy to translate into clinical practice. However, let's think about why it is important. It is important because the ICF takes us away from a cure or a fixing model to a biopsychosocial model, which is focused on somebody's moving my slides, please. It is a model which focuses on biopsychosocial model, which is functioning and participation. It focuses on what an individual can do rather than what they cannot do. So it is a positive framework of human health and well-being. So with the difficulty in translating it into clinical practice, something else happened, which was around 2013. A seminal paper was published by Peter Rosenbaum and Jan Willem Gorter, and it refers to the F words in childhood disability. I swear this is how we should think. And what they did was they gave us a very simple tool by which we could put ICF into our daily practice. And here are some examples of how that can be done and the basic idea of how they actually linked up the ICF with the F words. And you can see that with the body structure and function, we are talking about fitness. With activity, we are talking about functioning. With our participation, we are talking about friends and all the games and play that we do. The most important environmental factor for a child growing up is their family, and then the personal factors that related to fun. But they added in another dimension. We know that children grow and grow up to be adults, and they added a sixth dimension, which is the future. So these are the 6 F words. It's a very transformational idea because it actually has allowed people, not just clinicians, but families, to use it in their daily context, and it has allowed us to also have consultations which are much more focused on the child and the family. You can go on to the CanChild website. There's a separate F word section. There are translations into all, not all, a large number of language. Most of the languages within our region are available. Here's an example of how it's been used by a young person called Alfie, where he talks about the different priorities in his life, which allows us to have a conversation with him regarding what his goals are going to be. It doesn't have to be written, so it can be also pictorial, and it is another example of Vasily and Daniela, who produced this pictorial one showing their priorities in life at that given point. Second important concept I want to share is around family-centered services, so or FCS. What is FCS? It is an approach to service delivery that recognizes that the family is central to everything that we do with children who are facing challenges with their health or development. And there are underlying three principles. The first principle is that parents know their children best. That is, they are the experts in their child and they want the best for their children. Second principle is that each family is different and unique, and therefore, whatever we are planning to do with an individual child has to be tailored to the needs of that particular child and family. And the third principle is that optimal child functioning occurs within the context of a supportive family and community. There has been significant research which shows that if we take a family-centered service approach, putting the child and the family at the center of everything that we do, the outcomes for those children are better. And not just that, the outcomes for the family, the parents, is better. A lot of these service delivery models are not necessarily child and family friendly. It causes a huge amount of stress for families. And there is research to show that the mental health of parents or other caregivers can suffer. So if you want to find out a little bit more about how we can develop family-centered services within your own practice, we have a very good resource pack which is on the International Alliance website. We have a knowledge hub, and this is something which you can check out. Moving on to a third important concept, which is around participation and inclusion. It is part and parcel of the ICF model. So what is participation? The participation essentially refers to being involved in a life situation and is the key to an individual living a good life. Living is about participation in things that are meaningful to each one of us. And to enable this meaningful participation to take place, three things need to happen. The first thing is whoever is going to participate has to be interested in that activity. Without their interest, that participation is meaningless. And not just interest, they have to be there to be able to actually participate in it. So that is the attendance. So interest and attendance. The context has to be right for that particular individual. And the environment needs to be optimized to allow that individual to participate. So if you think about a child, say, who's in a wheelchair, has, say, GMFCS 4 cerebral palsy, and they want to play basketball, if we just take them to a basketball court, that's not going to achieve much. So you need to adapt the context and the environment, and removing the environmental and the context barriers in any setting, that is what is referred to as inclusion. And to allow true inclusion, it is about finding out what an individual wants and then being able to remove those barriers to enable them to participate. If you want to find out more, I've put in a link there, which is a little 10-minute YouTube video produced by Christine Imms, who's the queen of participation, if you like, and it is a really simple way of understanding a little bit more about participation and inclusion. Next important concept to understand is about describing and measuring functioning. So what is functioning? Functioning is basically doing things. It allows us self-efficacy and independence. So not only does it allow participation in life situations, but it also allows us to do our own activities of daily living. So we need some method by which we can reliably describe and measure how we are functioning. And that allows us as clinicians or as a wider community to have a common language. So for example, if we have a child or an individual with cerebral palsy, we have the measures like the GMFCS, MAX, CFCS, EDAX. I'm using acronyms, but these are measures of functioning, which allows us, even if I say today, this child has a GMFCS of 3, most people who are familiar with that would know exactly what the child is able to do, what the child is not able to do. To measure function at a given moment, there are certain tools, and there are other tools which can measure function over time. So it is important for us to understand what each individual tool can allow us to do. For example, GMFCS will give us the functioning of a child with cerebral palsy at a given moment in time. It is not a tool which can measure change in function over time. For that, you need the GMFM, or the gross motor functional measure. So it's important to know what the validity of that particular tool is and which population it is has been developed for. Next concept is non-categorical ways of thinking. So we have many commonalities across all the different childhood disabling conditions. And if we use a neurodevelopmental approach with shared principles, even across the different diagnoses, we can provide advice and manage most areas of functioning. And what do we mean by that? So areas like sleep, pain, feeding, continence, drooling, and even large areas like mobility, communication, behavior. If we understand the underlying principles, we would be able to provide advice and also manage a whole range of different conditions, irrespective of what the underlying diagnosis is. Understanding these common principles, learning about it will help clinicians, but also families navigate most of these functional difficulties. This is a very important concept, and I think the more we use this concept, the better it is in a way for us to be able to provide common platforms for families. Next important idea, which actually has become increasingly important and adopted by our community in the last 10 years, is around the life course health development approach. We know that children will grow up to be adults, so children with any neurodevelopmental condition will usually become an adult with that neurodevelopmental condition. Now, previously, a lot of children, particularly with complex neurodevelopmental conditions, may not have survived into adulthood. But over the last 20 years or so, there has been phenomenal improvement in what we do as neurodevelopmental communities to enable these children to thrive and to reach adulthood. And therefore, we have to follow these ideas of how do we follow a life course approach. And there are three major principles here. The first is to understand that there are certain interventions in early life which has impact on health function and participation in later life and adulthood. I'll give you a simple example. For example, a child with cerebral palsy, GMFCS 4 or 5, we know the trajectory of this child is that they will not have independent mobility even as an adult. So the quicker we give them aids, to whether it's a powered wheelchair where it is feasible, or other kind of aids depending on your context, which allows them mobility, allows them to explore their environment, the better they are going to be functioning as an adult, both in their social context but also in their mobility. Same things apply for communication and other things. The second thing to understand is that the health trajectories of different conditions are not known. Cerebral palsy is probably the best one where we know how this condition is going to evolve into adulthood. But these conditions where we do not know, we need to be able to track these trajectories. We need to understand the set of problems or challenges that present in childhood are not the same set that present in adulthood. There are different things which evolve, and we need to be able to anticipate and manage those challenges. And the last principle, of course, is that the care of the adults with childhood onset neurodevelopmental conditions are usually done by adult physicians, not by us neurodevelopmental community pediatricians or other people who are involved in their care as therapists or educators. Now, they have very little knowledge about these conditions, and it is important that we bridge this knowledge gap. And it is up to us as a community to develop this knowledge. And there is a lot of work going on trying to create those resources. Another fundamental concept is around evidence-based or evidence-informed care. There has to be evidence of effectiveness for everything that we do in our management. And that evidence has to be relevant to our local context, environment, and population. Like it or not, a lot of this evidence is being produced in high income countries, and we need to be able to either develop our own evidence for our own context or be able to adapt that evidence to our context. If you are adapting any kind of evidence, we need to provide the validity. We need to be able to do studies which show that it actually is effective in our own context as well. So when we take an evidence and we do a local adaptation, then it becomes that evidence informed practice where we've adapted it. Next concept is around goal setting in clinical practice. And this is something which we all do. So important concept is that we should do it jointly with the families and the children. They have to be smart. And ideally, they should be focusing on function and participation, which are meaningful for that child and family. There are validated tools which are available. I've put some names out there. And here is an example of goal attainment scaling. And if you just look online, there are various examples. They are not that difficult once you start doing it and you do it a few times. It is very easy and it is actually very good in terms of effectiveness or monitoring what kind of um, progress or not your child is making with the interventions you're doing. Another key concept is quality of life of children with disabilities. The quality of life brings together a whole range of ICF elements, and this is to reflect a child being happy, well, and content in their own context and in their life experiences. We know that there are certain things which can influence our quality of life, like peer inclusion, pain, independence, autonomy, etc. There are some validated screens developed in high-income countries like KidScreen. I think we need to develop validated tools which are relevant for low and middle income countries within our own context. There are two types essentially. One is self-report, where the child or young person can actually give their own report, or there is the caregiver report when the child is not able to provide their own report. What's important to recognize that the perceptions between children and their parents or caregivers can vary. Quality of life is subjective and it is every individual to every child and family. So with the same context and the same conditions, the perception of quality of life can vary between two individuals. And therefore, we should not make any summary judgments because they can be dangerous. Also in our clinical practice, for example, if I'm working in intensive care and I see a child with complex disability, if I make a judgment on their quality of life and take my clinical decisions, that could be very, very wrong. And we need to guard against these issues and understand the issue of quality of life. One important thing to also share is that a lot of children in developed countries where this research has been done feel that their quality of life is not inferior to their non-disabled peers. Those studies do not include children with life-limiting conditions. Another key concept for us is the multidisciplinary team, interagency working, and non-hierarchical ways of working. We are all managing complexity, multimorbidity, frailty, and we need multiple different skill sets, which requires a team of different disciplines, all with different specializations, different knowledge base. So we need to be able to respect each other and we need to be able to function as a team where communication is open and there is no hierarchy. Because where there is hierarchy, communication is stifled, and that does not lead on to good outcomes for children and families. Another important concept is transdisciplinary work, which means, say, if I'm a therapist and I'm a physiotherapist, for me to understand the principles of occupational therapy, of speech and language therapy, it's very important because it would allow me to actually think very laterally and provide some interventions which will work across the other disciplines too. And the last and important concept I want to mention is a children's rights-based approach. So we have two important rights conventions. The first one being the United Nations Convention on the Rights of the Child, or UNCRC, which has 42 rights enshrined. The ones which are particularly relevant for children with disabilities is right to health, right to inclusion and education, right to respect and dignity, right to information. And then you have the UN Convention of Rights of Persons with Disabilities, which has separate article on rights of children and rights of women with disabilities too. Now, why do we need to do this? Because allowing us to use this along with other partners, which includes families and adults with disabilities, families of children with disabilities, allows us to make arguments and be able to articulate our arguments to policymakers to get the right kind of services in our context or wherever we are. So we need to be strong advocates for these rights, and I've put some of these rights into a word cloud, and I think we all recognize all of these different words. Thank you for a patient listening. I'm sorry, Zafar, I suspect I have exceeded my time, but I'm happy to take some questions. Now, here is a disclaimer, which is that a lot of these ideas, or all of these ideas, are from a chapter called Fundamentals, which is part of our course on child development and disability essentials from McKeith Press. I'm the author of that chapter, or one of the editors, and these are available as single chapters, and I think in low middle income countries it is around £15 for access to any individual module. I'm just going to stop there, and thank you again for this opportunity.
Thank you, Dr. Nafsil. I request Dr. Basaraja sir to
Thank you very much, Dr. Jafar. And Dr. Arnabji, thank you very much. As expected by you, you have brought in a very, very important concept, what we are lacking at in a developing countries, where the care of a children, which has to be on the family-centered care, is in a very much required, and and also the health developmental approach and evidence-based approach that's what we need to be goal setting in the clinical practice using a smart principle. That's something which is very important. How the quality of a life, especially bringing together in a different ICF elements. That's also one of the thing which we all need to embrace. Thank you very much. All these concepts are very, very relevant in the care of any children, and also opening up one more thing, which is caring up in adulthood. That's something which is really we need to work, because transition care is one of the thing which is been lacking in Indian context, where the Indian Academy of Pediatrics, which is working out not only to the neurodevelopmental disorder and also diseases like thalassemia and the other neurodevelopmental disorder too. So your talk will open up a lot of avenues to think and think. It is a very thought-provoking talk, Dr. Arnab Silji. So thank you very much.
Thank you, sir. Thank you, Dr. Basaraj, sir. I take this opportunity to inform that the Sanbepa has done an official MOU with Kenchild, and very soon we will be launching for in association with all the participant organizations of Sanbepa for South Asia, the various ICF core models as per the WHO norm. That MOU is already signed. We'll be declaring it in Trivandrum at the second World Congress. But I just wanted to thank Dr. Anna for reinforcing that what we did was the right thing. And we would be, sir, from your point, taking up the kid screen for South Asia to develop locally. So that will be on our agenda. Thank you very much, sir. Thank you, Dr. Basavaraja, sir. I now hand it over to Dr. Samir Dalwai, sir, to moderate the next session, and Dr. Riaz Mubarak to chair the session. Dr. Samir, please.
Yeah, thank you, Dr. Zafar, and good afternoon, and my greetings to Dr. Basavaraj sir for gracing the occasion today, to Dr. Riaz Mubarak, of course, to my dear friend Dr. Zafar Minai, as well as our guests from all over, Dr. Haim, I can see him, as well as our faculty, Dr. Sitaraman sir, Dr. Deepak ji, as well as Dr. Hashan, and of course, Dr. Arnab, for this wonderful, wonderful presentation. as well as all the other members of our chapter, Dr. Leena, Dr. Kawaljit, Leena Deshpande, as well as Dr. Ehsan, who has been doing such a wonderful job of chairing this Sanbepa organization. Ladies and gentlemen, as you are aware, and as Dr. Arnab Seal just mentioned, eventually he didn't complete before he came to the child's rights-based approach. And this is something which is fundamentally important, but perhaps not seen as much in India, because we are still in the mode of sympathy, empathy, and that we are naturally full of love for children, etc. But that prevents understanding and implementation of child rights. And I'm very happy to inform you that considering this, last year, Dr. Y.K. Amdekar, sir, our teacher, and myself, we went through the manifestos of 12 political parties of the Lok Sabha, that is the general election, and we found that there was hardly anything that was concerning children, because children are not voters. And then, under the guidance of Dr. G.V. Basavaraj, sir, Dr. Vasant Khalatkar, and all the other office bearers of the academy, we came up with a demand that there should be an independent consolidated ministry of childhood and adolescence in this country, because currently all of the children's issues are divided across various ministries. And Dr. Sivprakasham sir is also here. He would know that if it comes to education, there's a separate ministry. Health, there is a separate ministry. Nutrition and childcare, there is a separate ministry of women and childhood. But in all these ministries, the component of adult being there, the voter is adult. So the money and the budget is spent and focused towards adults, not on children. So unless you have an independent ministry in a country like India, which has such tremendous challenges, and with the challenge of internet and the challenge of child prostitution, trafficking, and the screen time and pornography coming up, until you have a accountable ministry, things are not going to change. So I would also request all of you today present here, as well as all the office bearers, not just from IIP and India, but all the societies that form the South Asia pediatric region, to look into this, to help and support the establishment. The whole idea is to bring accountability when it comes to children. So with this, I would like to proceed ahead. Thank you once more, Arnabda. It's always a pleasure to hear you. And we now go ahead to our panel discussion. We have three very, very eminent speakers today. And as always, we take a specific day of the month which we want to celebrate. This month, we had a profusion of great days. And of course, we all know that there was a Doctor's Day, as well as a Brain Health Day, as well as a Fragile X Day, as well as a Vision Day. And all these aspects were equally important. So we didn't want to lose out any of them. And for the first part on Fragile X, an update, who better could we think of than to get our own very dear Dr. Professor Sitaraman sir. We all know him very well, a very, very humble, gentle person. Humility that belies his excellent academic and administrative credentials. As we know, he's former professor and the head of the Department of Pediatrics at SMS Medical College. And if I may say so, he's also Dr. Basavaraj's teacher. As well as he's now running a very wonderful child development center at Jaipur. And he's also doing a fabulous administrative job as the Vice Chancellor of the Indian College of Pediatrics. And this has, in the last 1 or 2 years, has seen the maximum number of velocity of improvement and increase in the services that have been delivered under ICP. Dr. Sitaraman sir, we all respect you. We all look forward to hearing from you today on Fragile X and update. The stage is yours.
Thank you, Dr. Samir. Am I audible?
Yes, sir.
Yes,
Wonderful. Now, and I must thank everyone on the dais, basically on the virtual dais, including Dr. Basav, and really compliment Dr. Arnab for his beautiful deliberation. Actually, it's really thought-provoking, and the principles he has laid down should be put it in a textual this thing so that we can put it in our next journal which you're coming up, Zafar. Yeah, so we know exactly those 12 points are there as a take-home message for everyone. And yeah, as we had the last week, the 22nd of July was the Fragile X. Now, one tends to feel that what exactly should be an update in this? The current trend for any medical science for evaluation of any disorder is purely targeted towards the genetic evaluations. We have heard fairly a detailed description of the clinical material. Next, please.
Who is Saya? So Fragile X, just to go for the definitions, is an umbrella term for a group of disorders caused by a genetic mutation of fMRI, one gene on the X chromosome. Everyone has a fMRI gene, you know, and most of us have 45 or fewer of what they call CGG repeats. FXS inherited disorders basically affects the intellectual, behavior, and social development in both males and females who have full mutation of the fMRI gene. And this actually is basically a X-linked dominant, but you still find some of the females also be affected. We come to it later on. Next. So this is the kind of progression you will tend to see, clinical progression over the time. And till you find till the toddler stage, you are never in the situation where you are suspecting Fragile X. You know, and USA, they have started screening, so you may have 3 years, but we here are actually trying to not look into it till we are much later when the physical attributes are more prominent. But fortunately, now with the genetic workups being freely available and wide across the whole country, we are able to evaluate these children and suspect. If you suspect a child with development delay, we should go in for it. And especially the children with autism. We have to do a Fragile X in these children. Yeah. And so I am not detailing on the physical attributes because most of you are conversant with the physical attributes of this particular syndrome. Next. Like in the physical, we have the long face, macrocephalic, prominent. This is the classical description of a Fragile X. Yeah. But if you go down the line, you'll find there is not all the sort of clinical characteristics are visible in many of the children. And that is because of some degree of mosaicism is there. And sometimes you feel just intellectual disability alone may be there, or features of autism spectrum. You notice that nearly 30 to 60% of the Fragile X children may have autism spectrum disorders. While on the reverse, in ASDs, only 6% of them would turn out to be Fragile X. But still, picking up them is become extremely important for us because it has a long-term implications regarding the genetic workup of the family. We'll come to know about it later on. Intellectual disability is one of the major issues which causes disability in these children. Next.
So we have given you the slide control. You can go ahead.
Oh, really? Oh, thank
Yes,
you so much.
Is it working?
Is it not working? No, it's not working.
Okay, I'll do it. Yes.
Yeah. So this is what is basically the simplistic cartoon on the way the fMRI gene is transmitted. And here the only reason why I put it up was to explain why the girls are also involved. Here we find that if there is a mother who is a carrier, she may give her daughter the carrier status or a full mutation. But knowing that there are two X's here, I mean, people would feel that some of these girls, despite being a Fragile X, have got a milder symptoms. And this is why it is happening. Because when there are two X's are there, the normal X is actually balancing with the X which is not okay. And that, sort of brings about the clinical features to a milder aspect. Yeah. But and as such, we have in the males, of course, since we have an XY and any of them become an X is a carrier, it will become a full manifestation and they comes to the girls. Next.
So please try
Okay,
this
okay,
again.
I'll try this. Okay,
Yeah,
fine.
it's working.
Okay, fine. That's wonderful. Thank you. So what this FXS arises from is an expansion of CGG trinucleotide. I'm stressing on this because these are the things which you will understand when you go down when we are talking about the genetics of the whole disorder. And the repeat of iron at FMR1 gene and the repeat excess of more than 200 copies leads to an epigenetic silencing of FMR gene, causing an absence of a fragile X mental retardation protein, FMRP. Now, this is very important to understand. This is one of the single gene disorders. The genetic makeup is same, and what is influencing the phenotype is the epigenetics, which is covering it. And that gives us some hope in analyzing this particular disorder. Here you see a cartoon which shows that if everyone has a FMR1 gene, but if it's less than 345 CGGs, you'll find it's a normal development. On the other hand, if there's a DNA methylation, it causes gene silencing, and no FMRP is there, and it causes a full form of Fragile X. In between, if they are, then they go to permutation-related disorders. That is, they may be carriers, they may be a mildly affected Fragile X. No, sorry. Yeah, so we have 4 types of FMR1 gene problems, and they are typical, as I stated earlier, intermediate, which are also known as gray zone alleles, pre-mutations, which are unstable mutations of gene. The importance about this is that either they manifest or it passes on to generations, even to grandchildren, with the skip generation. But if they are pre-mutations manifest, they manifest later on in life in males in form of FX-TAS, which is a Fragile X associated tremor or ataxic syndrome. Or they go into the females where go into primary ovarian insufficiency, which is FXPOI. Fuel mutation, as I told you earlier, gives you the clear picture of the physical attributes of this disorder. So what does FMRP protein actually do? It's actually a RNA protein, binding protein, which plays a key role in biological processes related to synaptic plasticity, the neural development, cellular signaling, and crucial for maintaining normal function of the nervous system, especially the brain, where it represents about 4% of the brain's RNA. Now, currently, the testing methods which are involved are polymerase PCR, which all of you are aware of, and Southern blot analysis. These have certain limitations because it takes time for them to be evaluated. When we start understanding the genetic process, we have to 3 things have to be taken into consideration. One is the DNA methylation. Now, in this, what happens is the hypermethylation of FMR1 promoter and adjacent regulatory regions. This blocks the transcription, effectively silencing the gene, and despite an intact coding process. So, despite the fact that the child has got an FMR1 gene which is intact, it can be silenced, and this silence is potentially, but the fortunate aspect is this silencing is potentially reversible. And because of that, we have avenues of therapeutic interventions. So this is the hopeful sign which genetics has told us, that we can reverse the process which was causing the Fragile X syndrome. The histone modifications, which are also responsible for the epigenetic modifications, they condense around the chromatin material, causing the more they are, the more the manifestation of the Fragile X is there, because the inactivation is very excessive. Chromatin remodeling is the third concept which we have to take into consideration, where the large-scale chromatin structural changes are brought about as observed in FX. And this, due to R loops, that RNA-DNA hybrid structures form at the FMR1 locus and play a dynamic role in mediating the silencing. Now, you look at the things which are highlighted. The FMR1 gene silencing occurs via epigenetic mechanism with no mutation in the promoter or coding gene. Now, if targeted interventions are there, like demethylating agents, histone deacetylase inhibitors may reactivate the gene expression. Now, this is the hope we have for the future of these children. The CRISPR shows the potential to reverse the pathogenic epigenetic modifications. And we have hope for these children if they come to the family. I'll skip
Please,
that. It's the same thing.
5 minutes or more.
Yeah.
Sitaraman sir, please.
Yes. The clinical implications are reversibility, gene editing, and diagnostic advances. We quickly go through the features regarding the manipulations, we find that the loss of fragile X MPR protein leads to excessive glutamate signaling, and this particular has got a influence on the insula anterior cingulate parahyporal, which is giving us the features of inhibition, memory, and visuospatial processes. So we have certain targeted treatment based on what we have garnered from the genetic investigations. We find that glutamate receptor 5, that if mGlu-R5 antagonists and other like trophinamide, arbaclofen, or which is actually the congenital sister drug for baclofen and gaboxidol, have researched to have behavioral and cognitive symptoms. There have been few works on baclofen because that's easily available. So I don't know how much of it can be tried in these children. Minocycline, the targeted treatments are minocycline, where a 3-month double-blind trial, controlled trial on children and adolescents, which is basically a drug for diabetes. We find it improves anxiety and mood-related disorders. Lovastatin, which is used for the statin group of drugs, with parent implemented language intervention, what is PILI, is currently being carried out in UOG Davis Mind Institute, which finds the spoken language and behavior can be improved because speech is also definitely compromised in these children. Metformin, which is for diabetes, has also shown that ability to improve defects in circadian rhythm. Low-dose sertraline and SSRIs in young children with FX has found that there is a significant improvements in fine motor skills, visual reception, and composite T-score and Mullen scales of early development. Now, these are being tried by, and they have found that nearly around 60% of the study population showed a significant improvement. So, but there are certain associated findings in fragile X, like anxiety, depression, mood regulation, which can be taken care of by sertraline and fluoxetines, risperidone, aripiprazole, stimulants like methylphenidate, amphetamine for attention deficits, and if there's seizures, which are also commonly there in these children, 10 to 4, the levetiracetam can be used. Now, potential therapies for this, now after this thing, evaluation of genetic evaluation, we find this SPG601 is a BK channel activator, which has been shown to have good clinical trials in FDA in this phase 2. And zatolomilast, which probably we should be expecting in coming 2 years, which is an orphan drug, but has got effect on the cognitive benefits. There are certain RNA-based therapies, which I will not go into detail because they are still under research, this thing. But adoption of decentralized clinical trials, leverage some digital platforms, has made particularly easier for families to accept these treatments. And one of the most interesting part of all this genetic issues comes the nanopore sequencing for carrier screening. Till now, as I detailed earlier, we have not been able to pick up fragile X very early in life. Yeah, because they always present like a developmental delay. And if you have a high index of suspicion, you may pick it up. But then if you don't pick it up, then you have issues when it comes up later on in life. Nanopore sequencing for carrier screening has been a novel approach, which shows it's faster, it's comprehensive, cost effective, and can be done at newborn period. And we find that it fastens up over hours, you can get the results.
Sorry to interrupt you. We'll have to conclude soon, sir.
Yeah, that's why I'm continuing this last slide. So this is the sequencing, which is fast, scalable, and it is a multiplexing capacity with a huge specific repeats can be covered up. It has got a very friendly software. So finally, unraveling of underlying the genetic causation has given us an hope for early diagnosis and screening, and also given the directions to a design therapeutic intervention which could be modify the disease. Thank you so much.
Thank you very much, sir. That was an excellent, amazing presentation in just a very little bit of time. You were able to cover all the important parts of the update and such an important disorders. Thank you very much. So going just before we go ahead, I'll take the permission to just share one slide. And this is the slide of my dear teacher, Dr. Rashid Merchant, and it's a tribute to him. He passed away last week and we lost him. But he was a very, very, very avid worker in genetics and especially fragile eggs and clinically. So just my tribute to him on behalf of all of you. We now have the next speaker, and the topic is a very important issue: vision in neurodevelopmental disorders, because this is one topic that we really are not able to see much in detail. And the speaker is none other than Dr. Harshan Kavinga Pathiraja from Sri Lanka. And we are very happy to have such an accomplished person because he's an associate specialist in community pediatrics, lecturer in pediatrics, faculty of medicine, University of Kelaniya, Sri Lanka. So, Dr. Harshan, it's over to you for this very important topic. And I'm sure you'll be able to get us to see a lot more. Thank you so much.
Thank you. Thank you very much. I think I'm audible, right? For you?
Yes, yes.
Yeah. And thank you very much for this opportunity. And thank you very much for all these panelists and also everyone who is behind this stage. And you are doing a wonderful job. And I think I personally don't know much of you, but I have met Dr. Samir when he was in Sri Lanka for a conference. And we'll move on to the topic. So this is one of the really important one, vision in neurodevelopmental disorders. And in this limited time, what I would try to tell is, as community pediatricians or developmental pediatricians or therapists who are involved in this care of the neurodevelopmental children, how to suspect and how to diagnose, and then how to manage these children so that we can improve their vision to improve all the other developmental domains. So I think we'll move on with the lecture. I don't have the control of the slides. Okay, yeah. So now when we talk about the visual pathway, I think we know there are two pathways. One is the anterior path, other one is the posterior pathway. So the anterior pathway, which is kind of the hardware, where we have all the structures, which is starting from the cornea, going to the optic nerve. And that is the one which is capturing and transmitting the visual signals to the brain. And usually the most common problems in children related to the anterior pathway are these refractive errors, maybe cataract or strabismus. And sometimes if we talk about children who are born preterm, we have retinopathy of prematurity. But the most important part is the posterior pathway, which is the software actually. And we all know the damage to this area can lead to corticovisual impairment. Now, in this posterior pathway, what we have are three important pathways. The dorsal pathway, as you can all see in the picture above, it is the most basic pathway that we need, and that gives all the action and spatial perception. But the other two are the complex pathways. For example, the ventral pathway is important for example, the higher visual functions like visual memory, complexity, and object recognition. And there's another one, the third visual pathway, which is important for social perception. So these are the two pathways, and both are equally important. But when it comes to children with neurodisability, the one we miss is the problems related to the posterior pathway. So moving on. So vision when it comes to children with neurodisabilities, it's not just sight. So children who are already disabled, for example, it can be a motor problem like cerebral palsy, or maybe autism, or maybe speech delay, or it can be communication problems, or sometimes intellectual disability or learning problems. So on top of that, if they have problems with the vision, there can be complications of the already existing problem, and also that can lead to delay in development in other areas. For example, vision is one of the most important stimulus that is important for exploration and gaining experience for these children. And also this is going to significantly impact the child's ability to learn as well as communicate and develop essential life skills. And vision is also affecting the overall quality of life. So how we are going to detect these children is the other important thing. So we are moving on to the next slide.
Sir, please try once. We have given you the control. See
Okay.
that it's moving. It's moving?
No, the issue is I'm connected with the phone. That's the
Okay,
issue.
I'll do it. It's no issues. Let me see.
Okay, thank you. Sorry for that. Right. So now this is the most important as we talk about the 5Fs and then discussing the quality of life of these children. One important thing is now it's given that around 40% of children with neurodisabilities can develop vision problems. But not all of them are being detected. Now, one thing is that sometimes the physicians who are taking care of the child and the caregivers are more concerned about the already existing neurodisability. So the vision sometimes get missed. And also sometimes it's very difficult to grab that these children are having a vision problem. And the third is even though we suspect that there is a vision problem, sometimes these children are not cooperative to our typical visual assessments, and it's very difficult the standard test to detect that there is a problem with the vision. So how are you going to approach a child with neurodisability whom we are suspecting there is a visual problem? The most important thing is their caregiver or the parent, because parents are the expert observers of their own children. So we can prepare a nice questionnaire or we can ask some questions from the parent. Now, for example, I'm not going to go through all these questions because we are lacking time. But for example, we can ask the parents that does the child have a pretend like a preferred color, or does the child turns his head when looking at something, or does the child identify things which are moving and try to ignore things which are static, and also does the child attend to any pictures who are shown other than his own? For example, sometimes children will look at objects or pictures of objects which they usually see. But sometimes, if they present them a new thing, sometimes they try to ignore it. And sometimes they might have visual field preferences. For example, they might see objects which are shown from the right side, but they tend to forget or ignore things which are shown from the left. So all these questions can be asked, or maybe we can give the sheet for the parents to be filled later on. So from that, actually, we can come to a conclusion that there is a problem with the vision. Now, suppose after discussing with the parents, we suspect that there's a problem with the vision. Then what are we going to do? So moving on to the next slide. Now, as I told, sometimes these children who are neurodisabled are not, for example, they are not compliant with the usual visual assessments. Now, usual visual assessments are like visual acuity testing, visual field confrontation, checking for visual reflexes, and then the other complicated tests. Now, in this, if as a pediatrician, if we suspect there is a visual problem, what we want to do is we need to liaise with the ophthalmologist first and to see whether the anterior pathway is okay. But the problem comes if the child is having any intellectual impairment or learning problem, the normal visual assessments will not work. Now, I have given some examples. For example, a logma chart, K pictures, kilo charts, and then Cardiff charts. They are some of the charts we can use to assess their visual acuity, even though they can't recognize letters or numbers. Now, these charts actually, now, for example, these kilo charts and Cardiff charts, sometimes they are CVI friendly as well. And also, now, for example, these kilo charts, the examiner can also observe from behind the chart so that he can see what happens to the visual field or the eye movement of the child as well. So we have these charts, and what we need to do is we need to liaise with the necessary people to look at the visual acuity. So moving on, now, for example, if we say the child is not, like he's not participating well enough, he's not cooperative, then we have this visual evoke potential testing. Now, for example, now this VEP provides a non-invasive objective measure of the visual function, and this can be done, and this does not need the cooperation of the child as well. So even you can do it in infancy as well. That is the most important thing. And also, however, things can get complicated. Now, for example, children with complex neurodisabilities, they're more likely to have other conditions. For example, nystagmus, maybe visual scotomas or poor fixation, but that may be following epilepsy that might affect the quality of VEP. But VEP is a good option if the child is not cooperating or if the child is small. Moving on. Then, how are we going to assess the cortico-visual impairment, the posterior pathway? So we have built a lot of assessments over time, and we are usually assessing these 10 points. For example, the color preference, need for the movement, is there a visual field preference and visual latency? So they take some time to recognize an object, maybe a family object they take time to recognize, and also difficulty with visual complexities. And then light gazing, difficulty with distant viewing, atypical visual reflexes, difficulty with visual novelty, unable to recognize new things, and also absence of visually guided read. So 10 points are there. And there are specially trained therapists also who can assess the CVI, and we can liaise with those teams to assess the cortical visual impairment if we are suspecting. And we can categorize them according to the severity. For example, higher the mark means more typical. That means if they score higher, that means the CVI is less. For example, phase 3, we need only to refine the ventral pathway only. That means to refine something of complexity and object recognition. Phase 1, that means the CVI score is low, means they have lot to improve. So they probably have their dorsal arm intact. That is also poor. Then we need to work more with visual perception, color recognitions, contrast recognition, those kinds of things. So CVI assessment and tailoring therapies according to the score is very important. So how are you going to manage these children? So two parts, I think, is the problem with the hardware, is the problem with the software. Now, for example, if there is a problem with the hardware, that is the anterior pathway, we have to fix them, especially in children with neurodevelopmental problems. The most common management we are going is corrective glasses. That is one of the most common things. And also sometimes children might have amblyopia, that means a lazy eye. So squint is maybe due to the lazy eye. So eye patching is, or occlusion therapy of the lazy eye is one important thing that we can do. And there is place for surgical interventions too. Now, for conditions like cataract or severe strabismus, even laser surgery has been used in patients who are intolerant to spectacles sometimes. And for example, other issue we find is parents come and tell that even though the doctor has prescribed spectacles, child is not wearing them. So in these children, what we can go is now we have contact lenses or surgeries that put lenses in. So then the problem with the spectacles goes away. Then you need to think about medical reasons as well. Now, for example, children with autism who have very typical food preferences might not eat meat. Sometimes they go into vitamin A or vitamin B12 deficiency. So in these children, if they develop visual problems, we might have to replace vitamin A or vitamin B12. And children with cerebral palsy who are on hyoscine patches as a method of treatment for drooling, this hyoscine can cause impaired vision. So in these children, we might have to withdraw hyoscine patch, and we need to think of other types of medical therapies for drooling. So always it has to be a tailor-made one. So moving on, what to do for the software part. Now, this is where things get complicated, and we need the help of all the sectors. Now, this has to be a multidisciplinary team management. Family is very important, as well as therapists are very important. Apart from the medical team, the visual professionals that will include ophthalmologists and optometrists as well. And the other important group are educators. Now, why I'm stressing about educators is, now suppose if the child is having CVI, and because as correctly mentioned from the first speaker, that inclusion education is a right for the child, even they are disabled. So we need to discuss with the education sector and the educators how to improve this child's vision, how to facilitate things which is compatible with the child's vision. For example, we can increase the font size, or maybe we can we can change the way or where the child is getting seated in the classroom, the inclination of the table, maybe that will suit his visual fields, maybe changing the contrast of the text, reducing the complexity of the classroom. So everything is very important, and that's where the educators come into play. So everything can be like concised into environmental enrichment. So that means exposing the brain to rich multisensory experiences, and meanwhile simplifying the environment, reducing the complexity. And we have to go for adapted materials. For example, use high contrast colors, using familiar objects always, and also incorporate light to draw attention as well. And training these therapists or training the educators and gaining maximum use of them, and training the family is also very important in handling these children and handling the visual problems in children with neurodevelopmental disability. So moving on to my last slide, I want to wrap up things, and the take-home messages are: we need to look beyond the obvious. That means sometimes we might miss there is a visual problem because it is masked under the other major problems of the child, maybe neurodisability, other problems. And the assessment is very important. We need to have the cooperation of the other fields like ophthalmologist, optometrist, and the other therapists, for example, CVI therapist as well. And the management is going to be holistic. We can't manage these children alone. To improve their quality of life, all the medical professionals, the family, educators, and the therapists should function as a team to improve the quality of life. And thank you. And I'm happy to answer the questions. And my email is on the next slide. I think we are having some restraint time, so I'm going to stop here. Thank you.
Lovely photographs to end with, and thank you for your email ID. If you can take a screenshot for the photographs as well as the ID, and you can write back. So thank you, Dr. Hashan. You again proved that the eye does not see what the mind does not know, and you have not only opened our eyes, but you have also opened our mind to what we have to see for children with visual problems in neurodevelopment pediatrics. Thank you very much. We would like now to go on to the third speaker. Again, a very important topic, combining two issues today, not just the World Health Day, but also the World Brain Day. And to do that, we have a very accomplished, young, but very accomplished pediatric neurologist who's a very essential part of our chapter and an office bearer as well. That's Dr. Professor Deepak Dwivedi, who's a professor at Department of Pediatrics, Government Medical College at Rewa, which is in Madhya Pradesh. And he was formerly working as a research scholar in child neurology and development at the Cincinnati Children's Hospital. He has experience of many years, and he's a very avid academician as well as a good clinician. So it's our pleasure to present Professor Deepak Dwivedi. And for the next few minutes, the stage is yours on pediatricians and their brain health. So this is going beyond just the children's health. Dr. Dwivedi, it's over to you.
Thank you, sir. Hopefully I'm audible.
Yes, audible.
So, yes, yeah, okay, thank you, sir. So it is always hard to speak after stalwarts, actually. And when the session is ending and you are starting to speak, so most of people are thinking how soon it will end. And I will deviate from this topic today, what we have been discussing, and I will discuss what we all pediatricians are facing and how the brain health of us are very important. So let me begin and say that pediatricians face high emotional and cognitive demands, and burnout affects over 50% of pediatricians. So that is a very important strain in brain of pediatricians. That is a burnout syndrome. And I think many of us, most of us had at least one episode of burnout for sure, I think. So it felt that it is very exhausting and we cannot continue. And after post-COVID surveys, we show that the emotional exhaustion was 63% in 2023. So can I change? Okay. So what are the health challenges which we pediatricians face? Like chronic stress, burnout, decision fatigue, and emotional exhaustion are the most important mental health challenges which we are facing. So these are not actually the psychiatric disorders which I am discussing. but these sometimes lead to psychiatric disorders. So these are the some things which pediatricians and developmental pediatricians are facing a lot. And please change. So first is burnout. So what is burnout? Burnout is defined as the emotional exhaustion, feeling drained by work, depersonalization, cynical, detached attitude toward patients. So what we all see these days, that patients are fighting with the doctors and doctors are fighting, residents are fighting, and they are misbehaving the patient. We are seeing these things a lot, especially in Indian circumstances. So this is basically, most of the time it is burnout only. So patient and doctors are not misbehaved, or they don't want to misbehave with the patient, or they are not empathetic to the patient. It is only the burnout which leads to all the mishaps which is happening. And there is reduced sense of personal accomplishment. General pediatricians were 2.4 times more likely to report burnout than internal medicine doctors in 2021. So it was a study done, a very good study. So next, please. What are the factors which leads to burnout in pediatric practice? First is long work hours. So pediatricians practically has, being an emergency medicine, practically they don't have any work hour. Anytime a parent, especially in India, anytime a child comes with their parent, the child is very serious and please see. And there are very heavy workloads, especially in our country, and the high job demands coupled with low control. So most of, especially pediatricians, don't have any control over their work, because anytime the delivery starts, anytime so they have to attend. Most of the pediatricians attend the obstetric deliveries, and they are always have low control. Now, what are the issues with us, the developmental and behavioral pediatricians? So DPP professionals face long wait list. They're actually the workload is more, and there are very less DBP working in our country. So they usually have long wait lists and complicated cases. These long wait lists leads to pressure from all segments of society. And then there is non-reimbursed care. And because we see patients with long term, and there is actually no insurance practically covers a developmental and developmental patients. Expect I think the Niramaya scheme, which is only supporting almost 20-30% of the total expenses. So it is one of the stress. And now another stress is that there is increased emotional burden due to non-responsibility. So we are facing with a lot of illnesses where there is no response, practically no response to the disease, and parents keep on asking us the question. It increases the emotional burden on us. Next, please. So what leads to the neurological impact? Burnout alters the brain circuit, and it leads to amygdala, and mainly it affects the amygdala and prefrontal cortex. The symptoms and consequences of burnout are fatigue and detachment, loss of passion for work, increased clinical errors, and risk of depression and substance abuse. So clinical errors is a very important thing, which especially in overwork conditions in India, we are facing because of overwork and stress. And second, what many doctors, especially pediatricians, are having is substance abuse. So substance abuse is also directly related to the burnout syndrome. Now, next, please. I'm not control. Next. Now, after burnout, another thing which we face is decision fatigue. So modern pediatric practice requires countless decisions each day, from medical judgments to administrative choices and documentation. Next. Yeah. Over time, this constant decision-making demand can exhaust the brain cognitive processes and a phenomena called decision fatigue. So how many times happens to all of us that after a very busy day, when we are seeing last 4 patients, if we suffer decision fatigue, we just write some random antibiotics or write some investigations and send them home, and then we bring the come back tomorrow evening. So that is decision fatigue. So we all are facing this decision fatigue, and this sometimes leads to clinical judgment, clinical errors, or many times leads to over treatment of the patient and over investigation. Next, please. Next. Okay, the systemic review confirms that decision fatigue can lead to impaired judgment, decreased diagnostic accuracy because we are too tired to take a good history, highly likelihood of medical alerts and impulsive choices, and feeling not able to decide at all. Sometimes it happens that I'm not able to decide at all. Next. Next. Okay. Now another important thing which pediatricians, especially neurodevelopmental pediatrician, faces emotional exhaustion and compassion fatigue. Because pediatricians form deep connections with children and families, because as a developmental pediatrician, we see the same child for many years. And we sometimes get very attached to those children and families, especially in neurogenetic and neurodegenerative conditions where the child eventually goes, like Duchenne's muscular dystrophy. So the patient eventually passes, and that gives us a very the same trauma which the parents get. So because we are seeing them for many years, we are seeing for every 15 days, we know their name, we know everything, and then we tend to lose them after some time. So it creates an emotional exhaustion and compassion fatigue among us, especially in neurodevelopmental pediatrics. The symptoms are then it leads to loss of empathy, irritability, emotional numbness, and affects clinical patient relationships. Next.
So you have slide control.
Okay, thank you. I don't know. Okay, it's doing it. So now what are the remedies? What to do? So personally, I want to say that I had suffered a severe burnout like 6 years back. Then I almost stopped doing anything. So what I did was that first thing is the most studied and scientifically proven is mindfulness and meditation. It helps a lot. One of the most well-studied tools for physician wellness is mindfulness, meditation, and related practices. Mindfulness involves training oneself to focus on the present moment in a non-judgmental way, often through breathing exercises, meditations, and short gratitude practices, like remembering 3 things to be grateful for, 3 things good happened today, and many more things, like show them yourself some gratitude. In 2022, scoping review of 31 studies found that mindful practice consistently helped physicians decreasing emotional exhaustion and depersonalization, 2 core dimensions of burnout, and improving mood, stress response, and overall vigor. These are some of the examples, like digital mindfulness training. Hello, hello.
Yes, go
Yes.
ahead. We lost
Okay.
you for 10 seconds.
Okay. So, digital mindfulness training modules, smartphone app. There are many spiritual people who are doing this, and 5-minute breathing exercise at the end or start of day, mindful walking, yoga exercises, mindful based stress reduction programs in hospitals. These are some of the things which we can help. And as a regular practitioner, I can say that we at least 20 to 30 minutes daily, it helps a lot. It helps a lot of burnout decreases from this doing mindfulness. Another very important is sports. So I always personally play tennis regularly. So, but any form of sport offers physical outlet for emotional tension, builds social connection and peer bonding, encourages mindfulness through movement, enhances self-esteem and mental clarity. Another very important stress buster thing is books. Books is especially non-fiction books. If you are interested in spirituality, it's well and good. Non-fiction for books other than what we are reading for our studies and our subject. So it lowers stress level and heart rate, encourages empathy, provides mental escape and relaxation, fosters reflective thinking and self-awareness, and helps wind after demanding day in clinical practice. Especially, it's a very good habit to study something not related to our subject for at least 15-20 minutes before sleep. It also improves sleep also. Now, another is maintaining work-life balance. Boundaries are very essential. I have many friends in as a pediatrician who don't have any work-life balance. They see patients all the day and then they go and take the rounds and then again see patient at 2 o'clock in the night. But I personally feel that there should be a boundary where it is boundaries are essential. Breaks, flexible schedule, vacations, hobbies are very essential. Don't always worry about the patients. Worry about yourself, your family also, your nutrition, sleep, social life support. You go to the marriages of your friends and friends' children. Please do that. That decreases a lot of burnout syndrome. Peer support is very important. It is very important whenever anyone is feeling stressed to talk to your friend. Talk to your friend, talk to your colleague. Whenever you are stuck, when you are there in a very stressful situation, somebody has done some consumer forum against you. There are many stress for pediatricians. Talk to the colleagues. It always gives the answer. I personally talk to all my problems with my colleagues and I always get the answer. And last is institutional role. Institutions and governments have also a responsibility that their healthcare workforce should be in good mind, and institutions, governments, Indian Academy of Pediatrics, we should all try to help everyone to be in good mind, because what last I can say that healthy minds heal better and care for yours first. Thank you so much.
So I want to know who suggested this topic.
Why,
My
I
question.
think the point was it was a doctor's day and the brain day. I thought everybody sitting here is well versed with the brain and the neurodevelopment. So I thought the better would be the doctor who has his brain is getting involved. But great, Dr. Deepak, I really congratulate you. It was a great presentation for all of us. I think because we all could relate it. Uh, please, Kabir bhai, continue.
No, I'm saying it's wonderful. I think all IIP election candidates should get a free lecture from him every day. That's very important. So thank you so much, Deepak. It's a really wonderful topic, and I think we should do this almost very regularly and it doesn't help only listening once. We have to keep doing it again. My only personal thing I can say, which has definitely helped me, I've been following and reading a lot of Osho. So a lot of what you said is similar, but I think wonderful talk, and I hand it over. Thanks once again, Deepak, and I hand it over to Dr. Kawaljit Singh, sir, the chairperson of our chapter. Thank you.
Dr. Reyes, please, Dr. Reyes.
Yeah, back to you, Dr. Zafar.
I request Dr. Reyes sir to do. Dr. Reyes sir. Professor Reyes sir. Dr. Kawaljit.
Hello.
Yes, sir. Yes,
Yeah,
sir. Please.
can you hear me? Yeah.
Yes.
Yes,
The
we can hear
three,
you, sir.
yeah, the three presentation was wonderful. Each presentation was unique. The first, Fragile X syndrome, and I really found it very interesting with implications of autism and other disabilities, with Fragile X syndrome. But it was a bit more genetic. It was quite a very high standard, delivery from the professor. Then the second one about the visual development was very nice, excellent, and that was very helpful. The third one, which is very unique presentation, I should say, and hello. Hello, can you hear me, Jafar?
Yes, sir. Go
Yes,
ahead. Go
yes,
ahead.
yes, yes.
Yeah, Samir. The thing is, the third one is very, very interesting because nobody thought about the pediatrician. I was giving a round, giving a follow up with my trainees and others now at the moment. And one pediatrician was telling me just one of our Dr. Arjun is pissed off, and he has been working for long hours, and he is burnt out. So and at the same time, I was listening to these things. That was a wonderful presentation, and that's what we are also thinking about us. Sometimes it goes beyond our capacity to work, and so we work, and sometimes some errors also happen in our work, and we are badly criticized. So we must take care of ourselves as well. So that's very important. So anyway, thanks very much, and thanks for giving me the opportunity to listen to this as a chairperson. Particularly, Dr. Jafar Vinay was wonderful, and Jafar is my good old friend, and we hope to see Samir as well and other renowned pediatrician and developmental pediatricians in future and in the next meeting. Hopefully, I'll get a visa, and I'll be there in Kerala, and we'll be meeting hopefully. Thanks very much indeed. Thanks
Thank
for
you.
the invitation.
Thank
Thank
you.
you.
Thank you.
Thank you, sir.
Dr. Kamaljeet.
Thank you, Dr. Zafar. On behalf of IIP Chapter of Neurodevelopmental Pediatrics in Sanbepa, I thank all the speakers, especially Dr. Arnab Seal. I think time has come, sir, that India moves ahead now and looks at the childhood disability through the ICF framework. I think a lot of things needs to be learned. I think the integration which needs to happen will happen soon in future. And Sitaraman sir, as usual, excellent sir. Like you gave a totally different concept, like what Fragile X will be changing soon in future, I think. So a lot of things are happening on that front also. Dr. Hashan, you are excellent in your presentation on the CVI. Vision an important role, I think, in neurodevelopment. And I think the icing on the cake was Dr. Deepak's that who will heal the healer, I think. So that was, I think, very apt. And as usual, like he made the topic quite interesting. I think everybody, I think, will have some comments to make on this. But I think time is short, and we are soon going to meet physically. Too much of digital world for last few months, but I think Trivandrum, Kerala is calling. So we'll be meeting soon in God's own country in the coming month. Thank you, Dr. Basavaraja sir and Dr. Professor Riaz sir, and so many seniors and colleagues in the forum. Thank you so much. I think this is an excellent initiative, and we should try to do it more. But I think time is a constraint. So I think when we meet physically, maybe we'll discuss how to take this forward, because this is a very unique thing. And we have so much of world children staying in the Southeast Asian countries. The need is here. I think this needs to be addressed. So I think let's unite, let's brainstorm in the next month at the Trivandrum Congress and take it further. Thank you so much, and thank you, Dr. Indu, who, despite her busy schedule, helped us today in getting the whole presentation thing, Zoom thing on.
Thank you.
And
My
Dr.
pleasure.
Shyam, yeah, we did not see you, but we heard you, and she's an excellent singer. So I think that further, yeah. So I'll leave it at that, because otherwise, yeah. Now we see you. Thank you, Dr. Indu.
Thank you so much. So I think with the permission of all the seniors and the faculty speakers, we would like to wind up now. So should we, Dr. Zafar,
Yes.
Dr. Samir?
Yes.
Thank you so
I
much.
think we thank all the advisors and office bearers of Sanbepa, New Development Pediatrics Chapter, all the esteemed faculties, Dr. Basaraja sir and Dr. Riaz. We all invite and hope to meet in Trivandrum. Thank you, sir. Thank you very much.
Thank you very much. Thank you, everybody.
Thank you.
Bye, everyone.
Thanks and goodbye, everyone.
Goodbye, everybody.
Thank you.
Thank you, Deepak, for the tips. I am straight away going to do the 5 minutes suggestions you had given. Thank you.
Dr. Basavaraj sir, are you there? Bye bye. Thank you. Basav bhai. I think, yeah. All right. Take care, everybody. Shabina ma'am, how are you? Or mute?
You are muted, ma'am.
All right. Can you hear me?
Yes.
Yeah. Wonderful session. And it's just been wonderful exchange of knowledge, very enriching, very enlightening. And most important is sharing, not sharing of knowledge, sharing of the knowledge style of all over the world. So that's one of the most wonderful things.
Thank you. Thank you. Sharing is caring.
Yes.
Thank you, ma'am. See you soon.
Professor Hemsagar sir, thank you so much.
Hemsagar
Professor
sir,
Ehsan
thank you
sir,
so
thank you so much. I think we can take leave now.
Thank you.